I'm Wei Chen. I'm a professor of plastic surgery here at Cleveland Clinic. I'm a super microsurgeon, and you probably don't know what that means, but that's not directly relevant to today's talks, so I won't go into it. But if you're interested to find out what it is, it's basically a technique used in lymphedema treatment. I only have 15 minutes, so I will get into my talk. So I will talk about ICG, indocyanine green lymphographic findings in patients with lipedema. All right, so we've heard a lot today about what lipedema is and how lipedema can exist in isolation, which is the common understanding, and it's almost a dogma now that people believe that in early lipedema patients have healthy lymphatics. So that's what we were told, and the common belief is that over time, lipedema-related changes led to lymphatic injury. So is that really the case? So that's the question that we ask ourselves, and that's basically what evidence-based medicine is. We know what we know, and we also know what we don't know. And what we don't know, we set up studies so we can investigate. So that's what we set out to do. So our hypothesis is that lipedema can exist in isolation with healthy lymphatics, which is the current belief. And our method is that all lipedema patients referred to us, Cleveland Clinic Center for Lymphedema Reconstruction and Research, we would perform indocyanine green lymphography to look at their lymphatic system. All right, so I need to explain to you what ICG lymphography is. So ICG, indocyanine green, is a fluorescent compound. It gets excited by 700 to 900 nanometer wavelength near infrared laser. So it gives off fluorescence. There's no radiation involved. This is in contrast to lymphoscintigraphy, which uses radioisotope, and it's a nuclear active study. And it exposes patients to radiation. So this is the common injection site. By the way, these are diagnostic injection sites. They do not cover all available lymphosomes, but for diagnostic purpose, these injection sites are sufficient. So these are the ICG machines. They're all similar. All the companies, each company all said their machine is better, but they all work. So this is what it looks like when we use ICG to try to identify, this was injection of a breast. You can see how quickly healthy lymphatics would pick up the ICG and rapidly move the ICG towards the armpit. So we can use ICG to identify sentinel lymph node instead of using radioisotope to identify sentinel lymph node. So this is taken from Dr. Scallon's study. This shows you what's actually propelling the lymph. The lymphangion, the smooth muscles lining the lymph channels, is what propels the lymph. And this contraction, or peristalsis, there's an intrinsic pacemaking property to these muscles, similar to our heart. It has intrinsic pacemaking, but it's also modulated by external feedback, by neural input. When there's increased lymphatic load, the contraction amplitude and frequency increase. And this video, again taken from Scallon's study, you can see the contraction of the lymphangion. You can even see the valves. So lymph channels are one-way pipes. Lymph flow should be one way. It shouldn't backflow, similar to veins. All right, so ICG lymphography, I believe some of you in the audience have received ICG lymphography, but I can tell you probably many of you have received partial study or incomplete study. If you have received ICG lymphography and following injection, you were scanned immediately and without a delay phase scan, that is, in our opinion, an incomplete study. You need both an immediate scan and you need a delay scan, and I'll tell you why. We'll start out with the immediate scan. Immediately following injection, you've just seen the breast injection. In healthy lymphatic system, ICG gets taken up rapidly. So you can use immediate scan to evaluate the uptake, evaluate the pump velocity, evaluate the lymphatic anatomy. We know what normal lymphatic anatomy looks like. So anything that deviates from the normal anatomy tells us that something is off. And of course, sometimes you see dermal backflow or the disease pattern even during the immediate scan. But most frequently, okay, here's an example of what the normal study looks like. Here you can see linear pattern going straight up from the hand, and now we're getting into the upper arm segment. I'm going to lift her sleeve, and then we can see the ICG going all the way into the armpit, reaching axillary lymph node. And as I said, these represent the normal lymphatic anatomy, and each color lymph channel represents a different lymphosomes. So unless you inject that lymphosomes, the lymph channels in those particular lymphosomes won't light up. So wherever you inject, you will only see lymph channels associated with that lymphosomes. So this is what you see for the leg. Oh, by the way, it's worth mentioning that you can see that separate lymph channels that's isolated from the thigh. Those are the deep system, which there's a communication between superficial and deep system in the popliteal fossa behind your knee. Most frequently, these two systems drain independently of each other, which is now a focus of our research, the lymphatic deep system. All right, as I just said, you need a delay scan to see everything. So these are the disease patterns that we're talking about, well, except for the linear pattern. The linear pattern is healthy lymph channels. These are the functioning lymph channels. Splash, stardust, and diffuse all are pathologic. You don't want to see them. So why would we see them? In normal situation, following injection, ideally we do intradermal injection. ICG gets taken up by lymphatic capillaries that are inside the dermis, which is inside the skin itself. Then it gets sent down to deeper pre-collectors. And then the pre-collectors picked up the ICG. They, again, send the ICG down to the collectors that are just deep to the superficial fascia, as represented by the dotted lines. Okay, so now they are in the collectors. And as I've just shown you on the video, collectors have valves, have one-way valves, so they're supposed to move lymph towards our core. Now, if there's an obstruction in the collector, your body would try to compensate. Our bodies have amazing capability to compensate. So it's like taking a detour. And what you see on the ICG lymphography is a splash. If the obstruction is even worse, now your body would need to temporarily bring the ICG or bring your lymph flow to a more superficial layer, bypass the obstruction, and then get back down again, and that is seen as a stardust. If the obstruction is even worse, now it becomes diffuse. Now it's really superficial. You see it as just a big patch. As you can imagine, in patients with lymphatic dysfunction, this process will be slow. So if you inject and you scan right away, you'll miss out on a lot of the patterns. So when do you want to do the delay phase scan? Well, as you can imagine, following injection, if you scan immediately, you'll see something. If you scan in half an hour, you'll see a different set of images. If you scan at an hour, again, different. 2 hours, 3 hours, so on and so forth. Eventually, you reach a plateau phase at which the patterns no longer change until you hit the regression point. So where is the plateau phase reached? 6 hours. At 6 hours, ICG patterns no longer, actually, to be accurate, 83% of the patient reach plateau at 6 hours out following injection. And at 14 hours, they reach regression point. So that's when the patterns start to recede. Actually, I won't bring that up because I will run out of time. So if you look at this, immediately following injection, you don't even see any dermal backflow pattern in this patient. Yeah, we would be scratching our head, why isn't the linear pattern reaching the armpit? So we have a clue that something is off, but there's no dermal backflow pattern. And then by 2 hours, we can clearly see that. You can see that at 4 hours, we saw even more stardust pattern. And at 6 hours, it looked even worse than at 4 hours. And then from 6 hours to 14 hours, they remain relatively unchanged. And here's the situation for the leg. It's basically the same thing. The main idea is to do a proper ICG lymphography. You need immediate scan and you need a delay phase scan at 6 hours. By the way, the same thing would apply to lymphoscintigraphy. And 4 hours delay for lymphoscintigraphy is also insufficient, by the way. And so this is fairly classic for someone with lymphedema. You can see Stardust pattern. This was taken at 6 hours out, involving the entire forearm and the upper arm. So this is what we call lymphographic stage 3 disease. Now note that this is a lymphographic stage. This is not a clinical stage. And it's actually more relevant because this reflects true severity of the lymphatic system. So patient says, I have swelling, I have pain, I have 5 minutes, got it. All right, I'll skip this. This basically shows you that even though there's no dermal backflow, it's abnormal because the entire medial lymphosomes is missing. So once we're experienced and reading these images, we can get a lot of information. So this allows us to diagnose lymphedema, allows us to also know how severe is the lymphedema. And also, equally importantly, it allows us to track the patient over time. This is what you look like today. What about a year later? You can say, I feel the same, but what exactly is happening underneath the skin? What does your lymphatic system look like a year from today? We can repeat the study using reproducible conditions and then compare. So this is the staging system, which I won't go into. It also allows us to diagnose primary lymphedema. So for a lot of clinicians, the diagnosis of primary versus secondary is fairly simple. There's history of mechanism of injury, it's secondary. If it's not, it's primary. Right, I need to really go fast now. So this is our study showing that you can use ICG lymphography to track progress. Are you getting better? Are you stable? Or are you worsening? And all these patients had supramicrosurgical lymphaticovenular anastomosis performed, which is a lymphatic reconstruction procedure. And before is prior to surgery, after is it was imaged 1 year later. You can see unequivocal improvement. Of course, all these patients told us that I feel great, but to be objective means we don't take subjective report as evidence. And lymphedema cure, is lymphedema curable? Look at this patient. Don't listen to her. She would tell you lymphedema is curable, but look at the ICG data. And it also tells us the axiality, the flow direction. Typically in lower abdomen, we should drain towards groin. But if you didn't perform ICG lymphography, you wouldn't know this patient would drain to contralateral groin. Another patient drained towards the armpit instead of draining towards the groin. All right, I want to get to the outcome. The outcome is we performed ICG lymphography in 66 lipedema patients. Now, these patients were previously diagnosed by other specialists, vascular surgeons, vascular medicine, and all underwent ICG lymphography. 100% of the lipedema patients were found to have lymphatic dysfunction. Karen was just talking about how these patients have edema, how these patients would benefit from compression. Now here's proof why. Every single one of them had lymphatic dysfunction. 61% of them had patterns that are consistent with primary lymphedema. That's actually quite interesting. 26% show severe lymphatic injury. Now these patterns are actually more consistent with acquired lymphedema. And then the remaining show slow transit, just various types of abnormalities. They're relatively mild, but they're definitely abnormal. Conclusion. First of all, this is unexpected, and this flies in the face of the current dogma, thinking that lipedema can exist in isolation. Maybe, at least that's not what we have seen 100% of the time in the past 2 years here at Cleveland Clinic. So lymphedema is at least highly correlated with lipedema, and based on our finding, I think those with lipedema should get their lymphatic system checked. And also based on this finding, compression is well indicated. It's not just for pain. There may be underlying lymphatic dysfunction that your compression would help. Of course, further study with much larger samples would be help us reaching a conclusive conclusion. And definitely by next year, I believe we will have a lot larger sample size, and we will get back to you. Thank you.